Okay, good afternoon, everybody. Welcome to all of you here and to the many that we also have joining us online for this hybrid event. For those who don't know me, my name is Prasad Patil. I'm an assistant professor in the Department of Biostatistics over at the BU School of Public Health. It's my pleasure to welcome all of you to the Center for Health Data Science Distinguished Speaker Seminar. I'd like to start by thanking our partners co-sponsoring today's event. Those are the Hariri Institute, the Biostatistics Department, and the Providence Boston Center for AIDS Research. We're really grateful to everyone for their tremendous support in organizing today's event. So before I introduce today's speaker, I just want to mention some logistics. First, we ask that those who have questions to please hold them until after the presentation. Following the talk, for those who are here in person, we'll pass around a microphone so that everyone can hear audience questions. And for those who are joining online, please enter your questions in the chat window, and we'll collate those questions and we'll ask them afterward as well. So today's talk is also being recorded and will later be available both on the Center for Health Data Science website as well as on the Hariri Institute's YouTube channel. And lastly, following today's speaking program, we'll invite everyone here who's in person to stay for a networking lunch, okay? Everyone got all that? All right. So with all that said, it's my great honor to introduce today's distinguished speaker, Dr. Bhramar Mukherjee. Dr. Mukherjee is the Anna M.R. Lauder Professor of Biostatistics and Professor of Chronic Disease Epidemiology at the Yale School of Public Health, where she serves as the inaugural Senior Associate Dean of Public Health Data Science and Data Equity. With over 400 publications in statistics, biostatistics, medicine, and public health, Dr. Mukherjee is globally recognized for her research contributions in integrating genetic, environmental, and health outcome data. She's a fellow of the American Statistical Association and of the American Association for the Advancement of Science. And her long list of awards and honors include the Gertrude Cox Award, the Janet Norwood Award, the Sarah Goddard Power Award, the Carl E. Peace Award, the Jerry Sachs Award, the Marvin Zellen Statistical Leadership Award, and something that's near and dear to us here at BU Biostatistics because we award it, the Adrian Couples Award as well. In 2022, Dr. Mukherjee was elected to the U.S. National Academy of Medicine, and she's the founding director of an NIH-funded undergraduate summer program on big data, which she's directed since 2015. So I can't think of a better person to educate us on navigating representativeness and the lack thereof in our research and in our studies. She's a luminary in the field, so please join me in extending a warm welcome to Dr. Bhramar Mukherjee.
Thank you so much, everyone, and it's a real joy and pleasure to be back at BU. I actually had to accept the Adrian Couples Award during COVID, so I'm going to take this as a ceremony of that celebration and post-dated ceremony. But it is really wonderful to be able to speak in this room. I do not know how you can focus on the speaker when the surroundings are so spectacular. So when you get distracted, I completely understand. So I want to talk about bias, and as you know, bias to a statistician is very near and dear to our heart. But then there is a chronicle of bias which is permeating through society, which is going to be woven through the design of our studies, the bias in our beliefs, the bias in our parameters. So hopefully, I'll be able to narrate a larger story of bias in health research. So, but I want to start this moment with a note of gratitude, and I want to thank Professor Cheng for giving me this opportunity to present, and also the incredible work that you have put in to get the Center for Health Data Science launched. So thank you so much. Please give her a big round of applause. And I think that in today's world, any good cause needs champions. So I never thought that I will be giving a lecture in this spectacular building, which makes me feel that I'm inside a data science sci-fi, a matrix room. So, so thank you to all the generous donors and the university for making this building and the dream of data science possible. So the past few weeks have been difficult for many of us, particularly in public health. And I was feeling very depressed, and I want to start with that recognition that many of us are going through very difficult times. So looking for some respite, I ended up in a concert, actually in an old recital hall in Yale, hosted by the Yale Institute of Sacred Music. This concert was about conservation and music. So there were talks by ecologists about certain species which are becoming extinct, and those pieces were then, those soundscapes recorded by the ecologists on the field were converted into beautiful, were sonified into musical pieces. And so the pieces were called Communion of Oysters, Dreams of the Seagrass. The last piece was about a little bird called the salt marsh sparrow. So this salt marsh sparrow is going to be extinct by any prediction model in ecology by 2050. And so this is their habitat is in the coastal East Coast. This is very native to Connecticut and Massachusetts. And with the sea levels rising, their habitat is getting destroyed into the tidal wave basins. And so even with that notion of their existence, the salt marsh sparrow keeps singing. Unfortunately, the audio is not working, but what I had in mind for you is to hear the song of the salt marsh sparrow, because what can you do every day except to sing? And as data scientists, our song is to do our work through our lens of data, modeling, and equations. So I found a lot of comfort in that concert when the salt marsh sparrow, the last beat of the musical piece, the segments between the music got longer and longer. I'm not saying that data science is going to get ousted or dreams are going to be ousted by 2050, but it's our mission to sing. And so that's what I want to dedicate this talk to. So I want to ask, I really wish you could hear the beautiful singing of the bird. So the question is, who is in my study and what is the target population? So when we teach biostatistics or statistics 101, this is the first thing we start with, that who is in my sample and what is the target population? How do we go from S to P, from a statistic to a parameter? With modern data sets, that internal sample has become much more complicated than a simple random sample, right? I work a lot with electronic health record, and many types of biases in study design and data collection actually make that sample to be a non-probability complex sample. But then we still want to use that data because there is information in this data despite the biases, and we want to generalize our inference to a target population. And so throughout this talk, I'm going to talk about the internal sample as size small n and the target population as size big N. And whether you get included in a study is the indicator S equal to 1, which is going to be the topic of this talk. So my father is actually an actor and director in India. At the age of 85, he's still playing Macbeth. That's what I actually talk about when I call India. And so during COVID, I was doing a lot of work in India, and I forced my father to listen through one of my talks. And after listening to my talk, he was actually silent. And so I said, Baba, what's wrong? Like, you know, every child needs parental approval, including me. So I said, what is wrong? And then he very quietly said, have you ever heard the word pause? So, of course not, right? You have only 1 hour, and with technical difficulties, maybe 57 minutes. And so you want to impart everything that you know. So he suggested that why don't you divide your talk into 3 acts or 2 acts, depending on what time you have. And after each act, use an interlude, like an intermission, maybe with some music, and also allow the audience a chance to leave. So I think this is actually very pivotal, because we do, when some of the technical talks, we do need intermission to process the things, but also I think we should allow the opportunity to leave. I hope you don't leave. I hope I can keep my audience engaged, but you should know that you have that option. So the first thing, so I divided my talk, just like a very sincere daughter, into 3 acts. And the first act, I'm going to talk about the role of statistics in the era of AI, particularly generative AI. And then in the second act, I want to talk about data equity. I posted on LinkedIn that I'm the first person in the world with a job title consisting of data equity, so I want to defend that job title. And then in the third act, I want to talk a little bit, if we have time, on how a statistician thinks about selection bias. So, but before that, I want to start with the quiz. I want to ask you, when do you think the first textbook in statistics was published? And there's a point behind this question, because I want to say that statistics is a relatively junior or young discipline compared to mathematics or physics, some of the foundational sciences. There are lots of statistics majors in this room, and I can see some of my former students from Michigan. So what is a guess, a good guess? And I'm going to take the answer from this paper written by one of my colleagues, Alan Agresti, who is a very pioneer in categorical data analysis, but he wrote this beautiful paper which got published in the Scandinavian Journal of Statistics about how important textbooks are in propagating the spirit of a discipline. If you wanted like missing data to be taught in graduate school, then write a book. If you wanted survival analysis to be taught in a graduate school curriculum, then write a book. So he talks about that, and his answer about when was the first statistics textbooks written, I'm going to take this from this paper. Any guesses? Time periods? 1950s? Yes? 1935. Mm-hmm. So the correct answer is 1901. An economist, obviously, Arthur Bowley, who was teaching actually in the London School of Economics and Political Science, published this book called Elements of Statistics. And after that, in 1920s and 1921, came the whole revolution with Fisher and Pearson and so on. So this is a relatively young discipline, and now we have morphed into the era of data science. Data science has given us these beautiful buildings and also a liberation from the classical mold of what constitutes a statistician. So I do a lot of work in shrinkage estimation, where my game is to do adaptive weights and adaptive estimators. So I tried to propose a definition of data science, which is a weighted combination of statistics and computer science, right? And the weights are chosen in a data adaptive way depending on the problem that you have at hand. The problem with our traditional training is to be that W goes to 0 in some departments and W goes to 1 in some other. But now we have data science curriculums, for example, Michigan Biostatistics, where I spent my last 18 years before coming to Yale. We introduced a new program in health data science. Also, we have a classical master's in biostatistics. And both are growing and going with great success, right? It's not a complementary choice between traditional biostatistics and data science. But I think that there is a fundamental mistake, fundamental flaw in my definition, because I do not think that any data science can strive without the domain science. So I need to really expand my definition to bring in the statistics and computer science, the quantitative sciences, but also the domain science. And just like a perfect statistician, I changed that equality to be an approximation, because there are lots of unmeasured and measured things on both sides of the equation. So for me, for the last 18 years, that domain science has been public health. I was a mathematician who did not like people. I was very happy with pen and paper. But somehow I ended up in a school of public health, and data started whispering stories into my ears, and I was pretty good at translating them into a novel. So there is no doubt that there has been tremendous interest in the job title data scientist across academia, universities, and industry and government. So this is very flawed data, Google search data, but you can see that there has been a real interest and the line for the yellow line searching for a data scientist is far above statistician or computer scientist. So it has probably benefited all the disciplines that we have this new domain. And then coming to artificial intelligence, many of my computer science friends will say that obviously we're talking about generative AI, but artificial intelligence has existed for a long time, and probably point to this paper by Alan Turing in 1950 titled and talking about Can Machines Think? And I did not really connect the dots that this paper starts talking about artificial intelligence with a game. And that game is imitation game. So many of you have probably watched the movie Imitation Game. So how many of you have watched Imitation Game? Yeah. So I really wanted to put a slide with Benedict Cumberbatch on my talks, and this movie made it possible. So if you think about that team which was working in Bletchley Park, Alan Turing was building the machine and was the doer, but there was actually a very clever statistician on the team, I.J. Good, or Jack Good, who barely had a dialogue in the movie. And here you can see that he is actually really in the back and doing some optimum likelihood calculation so that the Germans do not figure out that they have cracked the code. So the statisticians were up in arms about it, that this is a misrepresentation of Jack Good's character and also his contribution. So there is something about the popular image crisis of a statistician, of doing silent calculation, being in the backdrop, not being in the front, leading projects. So sometimes it's really good to read thought pieces and papers by stalwarts in the field. So the founder of Harvard Biostatistics Department, Professor Marvin Zelen, wrote this paper in 2005 where he was asked to predict in 20 years how is biostatistics going to look like. And so this was his 8-point prediction, and you can see many of his predictions have come true, but 2 of them were astonishing to me, which talks about, one is that computer programs will be able to perform automated data analysis, and then the second one is computer programs will be able to diagnose and evaluate methodological inadequacies, right? So that's more than just implementing data analysis. This is almost co-piloting your methodological research. So here we are, standing here in the age of generative AI, and it's more important than ever to think about what data feeds into these AI models or training corpuses, what is in there. So it is a defining moment for data science because I know of people who are asking GPT or Gemini or Claude what stocks they're going to buy or sell, what drugs they're going to take. So it's really determining not just our scholarship, the scientific scholarship, but daily decisions. In this moment, I think it's very important to think about data equity and also what data goes into building these AI models. Because regardless how sophisticated the AI tools are, if the data is biased, then even the best algorithms are going to lead to incorrect conclusions and then lead to misguided policies which are going to enhance inequities. And furthermore, this is going to be reinforcing itself because there is no fix. It's an iterative cycle, and the disparities are going to grow larger and larger. So elegance of models is not enough. You really need to think about how to design your training sample and your input data. I just want to show you an example because a picture is more important than words. So this is actually taken from a paper in Nature in 2018, long before the generative AI revolution. So the images are being generated by a prompt, and the algorithm is extremely clever and brilliant using a stable diffusion process. No problems with that. But these are the prompts for a software developer, a flight attendant, a poor person, a terrorist, a thug, and these are the images that are produced. So obviously you can see that there is bias, not just in the training corpus, at a multi-layered level. So shall we upweight our underrepresented samples in our data set? And so that led to Google's Gemini debacle with the images. Did they get the weights wrong? And so this is something that many of my colleagues said, that a statistician, this will be a sniff test in terms of sample weighting and training samples. But you can see that there is a problem here, a big problem in terms of how training data sets are being used by these different generative AI tools. So there is a lot of positive impact that is yet to be seen, and lots of things are going on. But I think it's very important to recognize where the world's data are coming from. So I want to share with you this paper. Genetics is a field where it is very easy to do a data inventory or do an enumeration because people deposit their data to a central repository. So this paper in Nature Medicine created this very compelling graph that over time, how many human genomes have been analyzed. That's on the y-axis here. And in the x-axis, you see time. And the colors represent the different ancestry groups represented in genomic studies. And on this side is the bar of world population. So if there is anything fair, the world population was represented in genetic data sets, you'll see a smidgen of green in this plot, which you do not see. And that green place is South Asia, where my parents live. So I want gene-guided therapies to be optimized for my parents. Very simple goal. But the genetic data, the information on the red European ancestry is being assumed to be true. We actually do a lot of very wonderful models of getting the summary statistics from the red and do transfer learning to create cross-ancestry polygenic risk score. I have papers. And that's important to how to optimize the current data in a meaningful way. But it's undeniable that we need more data that's representative of the world so that we can optimize our decisions. This paper I really like because it does not just talk about the problem, it actually talks about a roadmap on how to increase information diversity in genetic studies through strategic funding, capacity building, but also putting global data sets together. We tend to work on our favorite study all our life, the local studies, but there are efforts, and I spent my entire career analyzing Michigan Genomics Initiatives and UK Biobank, but the world is bigger. So here in Boston, actually the Broad Institute put together this global biobank meta-analysis initiative where 29 biobanks contributed genetic data with more than 1.4 million people's genetic data and electronic health record. So more and more, if we actually expand our horizon and publish papers and think about these data sets, that will be wonderful for our profession and for our world. So with that sort of prologue, I want to go into defining what is data equity. I think I have made the case that data is not distributed equally all around the world. So again, I had planned some musical interlude following my father's advice, but the sound system here did not project, so that's not my fault. And so my father also told me to be aware of technical difficulties. I didn't listen. So I'm happy to take one or two questions if you have some, or I am happy to move on to the next act. Okay, all right. So what is data equity? So data equity, I want to define first in a very broad term that it's very it mirrors the notion of health equity, which I'm going to put in a moment, that it's making sure that everybody, regardless of their personal circumstances or beliefs or identities, can have equitable access to data science resources, products, and innovations, right? This is both in terms of availability of data and the quality of data. Very simple ask that everybody should benefit equally from all the work that we are doing. And this is if you think about health equity, which is a deeply researched topic in public health and in medicine and in social sciences, that everyone has a fair and just opportunity to be as healthy as possible, regardless of personal factors, beliefs, or circumstances and identities. So there are some common principles in terms of data equity, inclusion and representation in creating our data sets, thinking about our inference, thinking about our algorithms, privacy and confidentiality of data, ethics, and then what is our accountability and social responsibility in terms of how these tools and data are being used to optimize people's decision. And I just want to say that learning accuracy does not imply in any shape or form decision accuracy and implementation accuracy. So it's a long way to go. And similarly, for health equity, there are some general principles in terms of equal access, justice, fairness, sociocultural adaptation in how care is delivered, in terms of really thinking about health and human flourishing as a fundamental human right. When data is actually being used to optimize many decisions in health, then data equity is an essential pillar of health equity. But this is not going to happen unless you put health equity as a priority. So I took this slide from David Ansel, who presented on behalf of the Rush University Medical Center. When they really wanted to go into the neighborhood and change the health outcome, they sort of focused that as their primary goal and then figured out the rest of the benefit and the revenue cost. And the banner outside Rush Medical Center changed to who gets the chance to be healthy, right? So outside every data science fancy buildings, we should have a banner, who gets the chance to provide research data. People who are working on 3 jobs are not responding to your surveys. People who are differently visually abled are not responding to a survey. The incarcerated population is unseen. So who are the data struggle of the unseen? How can we capture that? So I proposed a course and wrote this paper recently on how am I going to teach statistics and mathematics students coming with technical background this notion of data equity. So this is taken from my course syllabus that I'm going to talk about computer science concepts, first basic notions of AI and machine learning, and then principles in terms of fairness, accountability, transparency, ethics, privacy, confidentiality, talk about algorithms and learners, but then blend it with public health concepts in terms of study design, collection, information bias, selection bias, representativeness, generalizability, causality, and of course, models and learners are overarching in both disciplines. But then this is not enough. The metrics are not enough. How do you wrap it in a bedrock of reflexivity and ask the questions which are relevant for your application? So I am a practicing statistician for 30 years. I did not know that there is a field called critical data studies where people have thought about how to put data as a topic of discourse and dialogue and bring principles from literary criticism to criticize data innovations and data products and AI chatbots. So how do we implement these principles at each step of the data life cycle? From design to collection to analysis to interpretation, translation, what can we compute and what is beyond computation with community engagement, with downstream consequences of decision making? I think we need a place to discuss data like that, which brings both the quantitative and the qualitative, both the social, cultural, and epistemological anchoring of data into our teaching of our students of data science. I do think that a School of Public Health is the right place to do this kind of work because we are at present at every arc of the data cycle. So for example, in terms of setting up studies, epidemiology and environmental health, model building, biostatistics and epidemiology, health policies, studying the consequences of the policy and the evidence, and then social and behavioral sciences and health behavior and health equity departments thinking about really how this is manifesting the decision-making process into society. We have expertise in every one of these domains to bring this notion of data equity together. This is not going to happen in a stats and data science department. This is not going to happen in a computer science department because they're not really doing studies, generating data. It's really, really important for us to do this work. So I have spent 20 years of my career, 10 years on data analysis, 10 years on linking different domains of data. It was mentioned genetic, environment, electronic health record. In my last 10 years of active life, I really want to see data equity emerge as a third pillar of our data analysis paradigm. Of course, I created this image by using DALL-E. So calling for change also means that statisticians cannot be in everybody's backyard. I truly believe that data scientists and computational scientists have a lot of role in how to influence change by getting on the field. It's not easy for us to go out in the field and collect data, but I decided to start doing this, and I just wanted to share 2 glimpses of it, how my courage grew over time in order to collect my own data. Not just serve on everybody's backyard. You'll hear this all the time, that statisticians play in everybody's backyard. But I wanted my own front yard, my own garden, and eventually my own forest. So I have been thinking a lot about how to bring my authentic self to my work, right? So I came from India in 1996 to study in this country, and I sort of decoupled my academic identity from my social identity, who I am as a person who grew up in India. And I have been reading a lot of how to bring my whole self. And this is relevant for all of us, that we decouple our academic identity, and maybe we're passionate about music or we are passionate about art. We just leave that behind. How can we integrate that dual self into our work? And I strongly recommend this author, Jodi Ann Barre, actually a Michigan alum, who wrote several pieces on how to bring your authentic self to work. So my first foray into data collection was in India. In 2015 to 2017, I launched this study with a pilot grant from University of Michigan, where Michigan students trained community health workers to collect data on iPad. And that data was stored into a Michigan server. We ran a very simple tree model to determine what kind of text messages are going to go to the beneficiaries in the village. And our focus was on maternal and child health. So this was a study where it was done in the province where I grew up, in 14 villages. And these are some snippets from the field where you can see that community health workers, our brand ambassadors, are actually collecting data and taking measurements. And so in a biostatistics department, the question is that where is the place for this kind of work? And my papers actually did not get published in technical journals. They were in maternal and child health journals. And my senior colleagues asked me, what is happening to you? And my response was that you made the mistake of giving me tenure. And so tenure is not to play it safe, to really actually liberate yourself and go do some of the things that you wanted to do. So last January, so as an extension of continuing to work in India, last January, this 2025 January, I actually went to very interior areas in India, in tribal villages, where Yale team is developing chatbots in local languages to support the work of community health workers. And here you can see an ASHA worker asking a question about the beneficiary in the local language, and the ASHA Saheli, the companion chatbot, which is running on an LLM, a multilingual LLM, is giving the answer. I do want to see the translation of the technology and bringing digital solutions to deliver care to the last mile. So this project is run by a group of individuals which started at Yale over the last 10 years, had grown into this NGO called Khushi Baby with 90 members in the team now. So I want to continue to do that. But then also, I think that in Michigan, as an associate director for the Cancer Control and Population Sciences, we wanted to create cohorts which are studying and capturing the problems and the issues of Michigan residents. So this is a cohort. Again, when you get sort of like boosted by little data collection, then there is no stopping. So I'm one of the PIs of this study, along with my colleague Lee Pierce and Dana Dolinoy. So we are recruiting patients from 6 environmental injustice hotspots in Michigan, 100,000 patients. And Michigan has always been a center of many environmental catastrophes historically. Many of you heard about the Flint water crisis with lead in water pipes, but it also has very high PFAS levels and air pollution levels. So the way we designed this study was to create this index of environmental injustice across the state of Michigan. This is the plot of the index. And 6 areas or hotspots emerged, and these 6 areas are around 6 metros. And we oversampled people from these areas, and this is we have 10,000 participants. This is a plot of the study participants' location approximately. So you can see that you plan something and it's actually happening. And there is so much joy in terms of seeing a study that you designed actually getting data. I cannot tell you how inspiring and empowering that is. So who is in my study? I asked this big question, who is in my study? So anybody who is a resident of Michigan. This is a truly prospective cohort study, 18 to 49 years of age. Our target is 100,000, but it's 25,000 each from white, black, Latinx, and MENA population, or Middle Eastern and North African population, which is a very special population around Dearborn in Michigan. And what are we measuring? We are measuring lots of stress and inflammation biomarkers, heavy metals, environmental exposure, measures of immune function, biological aging through epigenetics, metabolomics, survey questionnaire. So even from a data science perspective, this is really a great data resource because you're getting longitudinal prospective data over time on so many different domains. If somebody wants to study data science in longitudinal data, multimodal data integration, this is a great study. And it has a diverse population, so you do not have to sacrifice your data science challenges just to meet your ideal goals in terms of how science should look like. So this is our students actually recruiting participants. We have 10,000 participants in the cohort, 90,000 more participants to recruit. And MyCHAOS has sort of become a go-to place for Michigan residents when they have a concern about an environmental pollutants or disease cluster. They're coming to us, they're attending our webinars. So there is some value of translating data to the community and community engagement. So the last part I want to spend on everything that I have talked about in Act 1 and Act 2. If I did that, I would not get tenure in a biostatistics department. This is the truth. I'm not going to get tenure in biostatistics or statistics department because we have to sort of somehow align our expertise and technical innovation with the social goals. So I want to show you that how we bring that to the table. So this is joint work by 2 of my very brilliant students, Max Salvatore and Rituban Kundu. Both are going to be postdocs at Penn next year. Max is already there. And till we get fair and representative data sets, what are our statistical fixes? I want to talk about that. So I do believe, is there anybody from computer science here? Okay, I can now criticize them. But no, but I really want to say that if you look at the curriculum of any statistics and biostatistics program, in the last few years, we have almost every department has included more computational courses, more courses on big data, and more courses on machine learning and AI, right? I would really like the computer science departments to reciprocate by introducing one course on study design and how measurements are actually studies are designed and how data are collected. What I see in my computer science, my brilliant computer science friends, is always to take data at face value, right? Y given X. Where does Y and X come from? Yes, I'm predicting, I understand I'm predicting, but if I don't understand who these people are and what these measurements are, I believe that somehow the translation piece is going to remain incomplete. So when we do, I work a lot with electronic health record data, and the paradigm in terms of whole study design with big data has really changed, because in classical Neyman Pearson statistics, we really focused on maximizing power, assuming that bias is not an issue. We really developed our theory based on that. So when we think about bias, there are two sources of error. One is the random error, which is like goes away if you increase your sample size. But the systematic sources of bias, for example, selection bias, information bias, confounding bias, they do not go away when you have larger sample size. I'll even argue this bias term becomes much more problematic when you have larger samples. And today I'm just going to talk about selection bias, but if you're looking for an area to contribute, how to tackle multiple sources of bias in a statistical model, because the literature is sort of selection bias here, confounding bias here, information bias here, but when all three are at play, how do you deal with them? That's an interesting problem to think about. So I said that larger data sets actually amplify these biases. So in our modern observational data and electronic health records, we are experiencing the curse of large N. When I first started giving this talk in terms of how small is your big data, my medical school colleagues like, what kind of people are you statisticians? Really pathologically depressing, because forever you wanted more data because you don't have enough power and so on. And we gave you these large, very large data sets. Now you're seeing the curse of large N. So what is happening? What is happening is that suppose you have a true parameter T and you had a modest sample size, then your confidence intervals may be looking like this. So that helps you to cover up the bias, right? The true parameter is still inside the confidence interval because your confidence interval is not very tiny. But now with a very large N, your confidence intervals are getting narrower and narrower, and lo and behold, your bias is not changing because you didn't do anything to change your study design. You have collected more of the same data. So the bias is really becoming much more amplified compared to your variance. And as a result, you are becoming precisely wrong. If being precisely wrong is your goal of inference, I have nothing to say, but I think that that's usually not our goal. And so we need to really rethink our statistical toolkit, because in mean squared error, forever we focused on thinking about the variance, but the bias square is becoming the dominating term in these studies, and we need better tools of controlling for confounding bias, selection bias, and information bias. So one thing which is interesting is that when your interest, methodological interest in terms of bias reduction and selection bias actually coincides with what science people are also talking about, maybe not in those technical terms. So I always have enjoyed when the methodological papers actually see a parallel translation into an important area of science. So we are publishing these papers in statistical journals, biometrics and statistics in medicine and so on. And then there were several papers criticizing or thinking about selection bias into massive biobanks, which are getting published in scientific journals. So that dialogue starts between a statistician and a data scientist and a medical scientist, that how do you think about selection bias? I want to, if you remember one thing for my talk, I want you to think about this 3D world where in a typical study, which is well designed with a probability sample, for example, in Haynes, it can have a complex sampling design. But there is a fixed sampling design. You control the design probability of the sample, controlled by an experimenter. And that could be equal probability sampling, for example, S equal to 1, regardless of the patient characteristics or data, is equal, right? It's not a function of the patient level covariates. In most of this electronic health record and observational study, what is happening is that there is a probability of getting selected into or included into your study, which is depending on your data. And it depends on whether you have access to insurance. If you are partnered or not, you are more likely to see a physician. It depends on your age. It depends on your biological sex. And so how do I model this divine probability, which is unknown to me, has not been given by an experimenter? So what do? Our game is modeling. So a statistician creates this model of devise probability, something that we create. And our goal is to go from the devise to the divine. We do not know the divine, and we want to go from devise to divine. And so how good is that model for modeling selection bias? Your success for removing selection bias will depend whether you created a good model for this probability of selection. An electronic health record is a very good example of that. So where does math play in? I just want to show you a little teaser, because I know that people of diverse backgrounds are here in this room, is that suppose in this electronic health record data, many times you actually do association studies, where you are trying to correlate a disease phenotype D with covariates, say Z1 and Z2, and you have a selection model, how people got selected. So this is the model in the whole population that you're targeting. This is not conditional on your selection. But you have a biased selection where the selection may depend even on your disease status. That's the most difficult kind of selection bias. It depends on selection covariates W. Maybe there are overlap in the two models in terms of Z2, and it also depends on D, right? So what you can show, and this is the classical training of a statistician, that you can relate, if you have these two ingredients, you need nothing else, to show that the conditional model, when you condition on the model fitted on the people who are in your data set, relates to the true model by this equation. And I think that we are uniquely qualified as statisticians and epidemiologists to think about data in terms of measurement error, in terms of these different sources of bias, imperfections in data, and translate that into mathematical expressions and treatment of it. So what you can see is that this is an offset term, but the problem is, in case control studies, this offset term is free of Z1 and Z2. It's just a constant, so you can absorb it in the intercept and you can go forward with your inference. But in general, if actually your selection starts depending on patient level covariates, then the situation is a little bit more complex. But this equation actually gives you a framework to get started. You may not be able to estimate this function directly. There are lots of challenges here, but this treatment actually lets you think about how do you actually move forward. So the framework, the conceptual framework, is that you have a disease model, you have a selection model, and there is some overlap between the two, and then you have this offset term, which you can clearly write down in terms of selection and the disease variables and the covariates. So now, whether your method is going to work well or not really depends on how these variables are interrelated. Anybody who has done missing data or like causal inference, this will be very familiar to you, but this is a DAG for selection bias. How does the disease model covariates and the selection covariates are interrelated with each other? If the disease model and the selection model are not related after conditioning on covariates, then you will be okay with any of your naive analysis. But as the relationship between selection and what you are interested becomes more and more complex, you need to adjust for them. And even with lots of adjustment, you may not be able to fully remove bias. So when you think like that, this is a unique training of, I think, biostatisticians and epidemiologists when you think about sampling design. So instead of usual logistic score equation, your ideal score equation, if you knew the sampling probabilities, will be an inverse probability weighted logistic regression where you have this pi. But the problem is that I do not know this pi. I need a model for this. But the problem is I do not have any data on the people who are S equal to 0 in my study. So lo and behold, I need to bring in one additional study. So this is where the biostatistics literature has really proliferated and grown of how to do data integration with a non-probability sample after bringing in an external probability sample. And you may not know everything. You may not measure everything in both samples equally. Sometimes you'll make covariates. Sometimes you'll measure the treatment. So that's where the methods have really exploded in the last few years of how to do this. And so I'm not going to go into the details of the method, but the methods actually depend on whether you have individual level data on the external sample, or you only have summary level data, that I just know the demographics in the margins in the external sample, and how can you start post-stratification, calibration, and calculating that pi hat using external data. So most of the methods actually focus on that and how you can robustify those methods. So in one paper, we actually study this problem under the different DAGs, the selection DAGs, depending on the, how complex it is. And we show, as it is our responsibility as a biostatistician to show that if the selection model was misspecified, or if the selection model was correctly specified, under different DAGs, which kind of methods work. And sometimes it does not matter, right? Like if there is no, so you can decouple the selection model and the disease model that you're interested in, all methods may work well. But as the situation gets more complex, then you need more methods. And also, some methods are very contingent on specification of the model, and some methods are not. So you need multiply robust models. So writing that paper in terms of DAGs and equations is good, but you have to bring the results to the community who is going to use them. I have been a very strong believer of that, and so we published a follow-up paper which takes all of these tools and actually applies it to analyzing jointly and analyzing data from 3 biobanks. And I want to show you these 3 biobanks. So Michigan Genomics Initiative, this is a study of more than like 100,000 people. They were recruited as they are waiting for surgery in anesthesiology clinics. And then UK Biobank, which is known to have healthy volunteer bias, it's 40 to 69 age range and 500,000, nearly 500,000 people with all kinds of data. And the NIH All of Us, which is all adult population, target sample size 1 million, and it oversampled underrepresented groups. So you can see that these 3 studies, I cannot just put together and be happy that some statistical god is going to weave their magic. So we need to do something when we are putting this data together, and you need to really, your answer of what you are going to do depends on your downstream task. There is no one answer. Are you trying to estimate disease prevalence? Are you trying to estimate an odds ratio like I showed you? Or is your goal prediction or estimating a causal effect? Your methods and your choice and your answer is going to depend on how much you can do and how much does selection bias matter. So as I mentioned, in order to fix these samples from different places, we need to bring in an external probability sample. So what we did for the US studies, we brought in National Health Interview Survey, or NHIS. That's why this large-scale representative national data is extremely important for statistical research, because we can get some benchmark about the population. And for UK, we brought in the UK census microdata about what UK 40 to 69 population is going to look like. We also looked through the manuals of each of these studies to see what could actually influence selection. There is not a clear statement in each biobank that what should be the W and Z variables which can influence selection across the studies. So our final analysis, this massive analysis with lots of people involved, that we looked at all 3 studies in an unweighted way, and they differ quite a bit in terms of age and proportion of females, and in terms of the percentage of ethnicity, they are very different. And when we actually brought in the external sample and did the weighting, they looked much more similar to the target population, the NHIS sample or the UK Biobank sample. So, but that does not really tell me that, okay, matching on some margins is not going to preserve my association and every kind of analysis, downstream analysis that we are thinking. So what we did as our final algorithm is actually we weighted in terms of the propensity, in terms of the post-stratification weights, but then meta-analyzed with the inverse variance weight, the 3 studies, once we mapped to a target population. And the answer was, I wish that I said like, oh, you have to use weights all the time, but that's not true. Anytime when you are trying to estimate something, weighting is more crucial. If you are trying to estimate the prevalence of cancer from these 3 studies, you need to use weights because there is obviously 50% prevalence in Michigan Genomics Initiative and much less in other studies. If you're trying to think about correlation structures across the phenotypes, it was not as crucial. When you're thinking about hypothesis testing, many of the top hits actually remain preserved in terms of selection bias affecting the numerator and the denominator of your test statistics in similar way. But if you are actually trying to do estimation of the genetic odds ratio, it's really crucial that you curate your weights thinking about what are you interested in and what does selection influence. So after the whole exercise of doing the theory, applying it to a biobank data analysis, what we concluded is that weighting is not always the best answer. Sometimes when you have a good idea about the selection factors, it can reduce selection bias, not completely remove. So we really need methods in this area where we have selection bias, confounding bias, information bias together. And I think that we need more statisticians engaged in this area. I want to sort of end this piece by showing you that there has been a lot of growth in literature around electronic health records. So this is the Embase database queried with EHR, EMR, electronic health records, electronic medical records, and you see a steady increase in terms of the number of papers that you find. But this is the data distribution across the world. Again, I want to show you that North America and Europe, where 15% of the world live, generates 80% of these papers, right? With digitization of health is somewhere I think we really need to go. And again, India and Southeast Asia remains underrepresented. So what can we do? I definitely am a data dreamer, but I'm not the only one. On this bright, wonderful afternoon, you're all here with me. But I think that if you think about social impact, we are in a university because we get to influence the next generation. And there has nothing been more meaningful in my entire career except training the next generation. I have been running this summer program on big data for the last 10 years at University of Michigan and the first iteration at Yale coming up. We have trained 360 students. More than 60% have gone to graduate school. Many of them never heard about biostatistics. They are math and stat majors and computer science and engineering majors. And then you show them what they could do with the possibilities that are endless with their coding skills and solving an important problem in improving the human condition and human health. And so my last song was actually a song by John Lennon, but Imagine is going to just really play in your mind, not actually in the auditorium. But I just want to thank you by saying that please keep the population who is not in your data set at least in your mind. They are really wanting to be seen. And statisticians have an incredible ability of analyzing a problem and walking through it, and always value that conscientious statistician and keep them in the loop. Thank you so much.
All right, thank you so much, Dr. Mukherjee, for really far-reaching and thought-provoking talk. I hope it has provoked some thoughts in all of you. We have a little bit of time, I think, for questions. And again, if you remember my rules, just raise your hand. I'll acknowledge you. We'll get a microphone over to you if you're in the room. And then Laura is commanding the online chat. So with that, please let me know if you have any questions for Dr. Mukherjee. Yes, you can take my mic.
Hi, Dr. Mukherjee. My name's Madhuri. Thank you so much for this amazing talk. I feel like I want the recording just so I can re-listen to this. I have a question. I think you talked a lot about both local kind of studies and data collection, like in the villages in India, but also global, like very large data sets. So when do you feel like, I feel like you kind of have to balance, like sometimes I do a very local study and only have to collect data for this village, but at what point is it important to start collecting data about, maybe other states in India or other regions of South Asia, or start expanding? Does that question make sense?
Yes, absolutely. So thank you, Madhuri, for that question. So I do think that you have to, if you think about information, right? I love public health because it actually gives us a framework of integrating information at an individual level, at a community level, and at a social level across diverse communities. And then once you have data, you understand where the variation lies and the causes of the variation. And once you understand the causes of variation, you can advocate for change or intervention and prevention. So if we think about that as a goal of public health, that our goal is to prevent, not just predict, it will become very clear to you if you think about an intervention or prevention point of view that what interventions are global, what interventions are, like some knowledges are cross-cutting, across ancestry, across population, and some knowledges are has to be very micro-localized, right? Some interventions. So you get data depending on the question. Some of the large biobanks have really enabled us to look at problems of data integration at a massive scale. Without these sample sizes of 500,000, 1 million, we'll never be able to understand and characterize all of this multimodal data jointly. So kudos for that. But then with that knowledge, with that association, with that science, if I want to really enable communities, I also want to understand how this is working for the communities. So I'll give you one example that there are many drugs for cancer where we do clinical trials, and I work with a lot of hospitals in India. Sometimes the doses that are recommended just do not work for Indian women. And that's because the distribution of BMI or blood hemoglobin in Indian women is very different from that's represented in the clinical trial population. So the discovery of the drug is definitely important, but then you need also targeted trials in Indian population so that you can optimize the dose and actually optimize tailored to that. So I do think if you think about interventions and if you think about the question, it's very clear at what level of data you should actually collect, and both are important. And similarly, I think that this is important from a social and science point of view, but it opens up a lot of interesting data integration questions for the statistician in you, methodological statistician in you, that from the global study, maybe I know this is gigantic risk prediction model, and people have released that data. Now I have my small study with individual detailed measurements. I do not have that sample size. How can I borrow information from my large study? What is transferable? What is transportable so that I can strengthen my inference in my small study? So there is so much work in that domain as well. So I think that if you keep your goals aligned, it actually automatically gives rise to very interesting methodological and mathematical questions. Yeah.
Thank you.
Thank you. Other questions? Yes.
Just one from the chat. I think a really interesting question about in your combination of the three different biobanks. It was noted the UK biobank has around 90% European participants, much more than the other data sets. And so I think the question is sort of around when do you start worrying about these reweighting or adjustments breaking down? When does it lose reliability?
Yeah, so that was one of the major questions the reviewers asked about this paper as well, that if your, say, all of us design is oversampling underrepresented groups because you wanted enough sample size in each strata, why would you weight it to make it look like US population again? So the fundamental thing is that if you are trying to generalize to a target population, if your target population is not the entire US population, but you really want to learn about subgroups, then you should stratify first and focus on that particular subgroup and then do the weighting to make it look like the US representation of that subgroup. So the question is whether what is your target population? You should make it look much more like your target population. So having that framework, who am I trying to relate this information to? is very helpful in thinking about whether I should wait or not.
Questions? I think we have time for maybe one or two. Anything else, Laura, from the chat? Oh yeah, Debbie.
Bhramar, thank you so much for that amazing talk. You mentioned, we're in the midst of this generative AI revolution, and I was wondering if you could just share thoughts about what you think the role of biostatistics is in this, and maybe what we should be thinking about how to educate ourselves and also our students in biostatistics.
So first of all, I do think our students are far ahead of us. So every time I meet with my students, they have a lot more to teach me than I have to teach them. So maybe that's a point to retire. But I think that I sort of think that experimental design is a very important thing. How do you actually, do I really need to use everything in the input training corpus? Or could we selectively design the training corpus before fine-tuning an LLM? That's the first thing. I think experimental design, uncertainty quantification, obviously a lot of work is going on. I think that even computer scientists in academia are not thinking about building more efficient and larger LLMs. That boat has sailed. You really need to think about how we can use it towards positive social impact. And combining, say, for example, education in terms of health and medicine, how can we fine-tune LLMs to really serve a community which needs them and to really blend that domain expertise? The third thing is that in terms of education, I see a lot of potential of using fine-tuned LLMs for patient education as well as student education. So I'll give you an example. So in Michigan, they piloted this AI-assisted tutor called Maisie, which is integrated with the Canvas site of each course. And this AI tutor has really mined the past historical course notes and the videos and the lecture notes in order to provide personalized tutoring to the students. And not everyone shows up to office hours of instructors, right? To have access to a tutor in the middle of the night before an exam, I think is important. And they are also saying that after 4 years of your education at this AI-assisted tutor is going to learn your learning needs so well that you can take it as a personal education coach. I think like we are not preventing, right? I don't believe so. I basically taught a course where I said you can use any tool out there because I'm preparing you for research. And just like I cannot prevent you from using the internet, I'm not going to prevent you from using Gemini or Claude or GPT or DeepSeek. So if you use all of that, give me a very transparent statement of the prompts that you used. Did you use it to generate your idea? Or did you upload a paragraph and say that, can you make it clearer? I want to know exactly, honestly, how you have used and give me a copy of your prompts. I want you to use these tools gainfully, just like when I first started out my career, there were a lot of wrong equations in Wikipedia. And our professors are going to say, oh, you are making this mistake. Did you learn it from Wikipedia? And now, over nobody questions. It's like crowdsourcing of information has really improved the quality of that information. And so the hallucination factor of these tools are going to diminish over time. And we cannot resist using them. So my goal is to teach my students that don't be AI-driven, but really make your work AI-augmented so that you are efficient. Even if you think about Copilot, right? Like if you think about GitHub Copilot, if you wanted to translate previously a Python code into R, it took you a long time. Now if you actually ask Code Interpreter or other tools to translate that, it's not perfect, but it is doing 80% of your work. You still need to be very savvy to debug that 20%, which really brings in your expertise. But a part of your work is automatically done. So I really resonate with Marvin Zellen's prediction that some things will be automated, some things you have to co-pilot, and some things are going to be really independently driven. So after the invent of I remember my education in India, I used to memorize all of these theorems and formula, and I used to vomit those formula at exams. That was my education. But now I barely can remember any of this formula because I look up, right? So the internet has changed how we learn, and we have used our white space in our head to do something else. So we really have to reimagine what that something else looks like when some of our tasks can be delegated to AI tools. So that's what I feel.
All right, with that, I think we will wrap up for today. So please join me in thanking Dr. Mukherjee again for a wonderful talk. Before we move on to lunch, I just want to plug 2 more talks that are coming up as part of this series. So on Wednesday, April 16th, we have our next seminar presented by Dr. Deb Mukherjee from the Math Stat department here at BU. He'll be speaking on learning from data, 2 aspects of fairness. That talk will be held at the BU Medical Campus. And then Wednesday, May 14th, we have another distinguished speaker seminar with Dr. Mary Gray, a senior principal researcher from Microsoft, talk to be announced. That seminar will be also held at the BU Medical Campus, so I hope to see at least this many people at both of those. All right, thanks a lot, and lunch is in the back.